Welcome to our CDC webinar today, HIV Data in Action, using HIV data to prevent infections and improve health. My name is Erica Dunbar. I serve as the program lead for our health department and community-based organization initiatives in the prevention program branch here in the Division of HIV/AIDS Prevention at the Centers for Disease Control and Prevention. And we'd like to welcome you to join our webinar for today. We are at an exciting time in HIV prevention. We have the tools to stop HIV, but we have to work together to focus on the communities most in need. And as we think about new approaches to identifying those communities most in need, it's critically important that we hear input from our partners on how we can best implement this work. So it is important for us to talk to our community partners and have this webinar with our HIV planning group members. Our HIV planning group members have a very important role in our routine prevention work, and your involvement is important in helping to put this work into the context of our existing prevention efforts. So you serve as that link between the health departments and the communities. As we continue to strengthen our ability to use surveillance data to make sure our prevention efforts have the greatest impact, we felt that it was important to make sure that our HIV planning group members understand and are able to speak to how we use data to maximize prevention efforts. So using the HIV data to prevent new infections and improve health for HIV. We see this as an opportunity to hear from you and about your thoughts on this work and prevention and surveillance tools. And we look forward to discussing in the latter half of the hour. But first, we want to start with a presentation, and at this time, I am going to turn it over to my colleague, Dr. Alexa Oster, team lead from our HIV Incidence and Case Surveillance Branch within the Division of HIV/AIDS Prevention here at CDC. Alexa?
Thanks, Erica. Hello, everyone. I'd like to thank you for joining us today. Over the next 20 minutes, we'll talk about how, in this era of better treatment and prevention options than ever, the HIV prevention landscape is changing, and how we're integrating traditional public health practice and new technology, including the use of molecular data, into HIV prevention and care efforts. We'll then move into a discussion during which we hope to hear your input on these topics. CDC has provided guidance for including communities in planning for HIV prevention programs since 1993. And existing HIV programs were shaped with significant input from communities. CDC and state and local health departments continue to support engagement with communities and partners in prevention with three aims in mind. First, to increase our partners' understanding about how and why we use data for HIV prevention purposes. Second, to increase CDC and health department understanding of community concerns related to the new ways we are using data. And third, to identify ways that we can work together to address these concerns and minimize risks associated with these practices. We are at an exciting time in HIV prevention. Testing is faster and can detect infection earlier. If that test is positive, we know that treatment saves lives and prevents transmission. And for those that are negative but are at risk, we have effective prevention options, including PrEP and PEP, condom distribution, and syringe service programs. And we now have improved strategies and interventions to reach populations in need of prevention, care, and related services. We all share these HIV prevention goals, which include ensuring that people with HIV live healthy lives, reducing the number of new HIV infections, and reducing HIV-related health disparities. As I just mentioned, we have some great prevention options. However, we still have some major challenges. Some groups are at very high risk of getting HIV during their lifetime. For example, communities of color, gay, bisexual, and other men who have sex with men, and people who inject drugs. We also know that we have groups that are at risk for outbreaks. People's health is on the line, and to achieve these prevention goals, we need to use all tools available to us. Let's start by talking about traditional public health practice. Public health helps people and communities. In order to understand public health problems, CDC and health departments monitor and report illness and other conditions. This is called public health surveillance. The word surveillance can have different meanings in different situations, but public health surveillance has a very different goal than some other types of surveillance. And the information that health departments gather guides public health policy and prevention strategies to keep people healthy. Public health surveillance has been used for more than 100 years for a variety of conditions, like foodborne illness, cancer, and tuberculosis. This monitoring is important for detecting developing outbreaks. For example, public health data help to find outbreaks associated with contaminated food and keep the food supply safe. It's also important for helping people at risk to stay well. For example, when public health identifies a community with increases in tuberculosis, it can help to get testing and treatment to the people who need it. Overall, public health surveillance helps us to target limited resources to the people in areas that need them most. For example, public health data help to identify states with high rates of drug overdoses, which can help to make sure that they have resources to prevent overdoses and treat opioid use disorder. Without public health surveillance, our society couldn't prevent illness or provide care as effectively. Public health data that we collect through HIV surveillance and how we use those data, including the extent that those data are used for public health prevention and response activities, have evolved over time as our understanding of HIV and of prevention has evolved. From early on, public health data was the best source of information to describe who was being affected by HIV and where the virus was spreading. Until antiretroviral treatment became available, there were few recognizable benefits for individuals personally to health departments collecting HIV data. Why would they want to risk a loss of confidentiality? This was central to the debates around name-based reporting of HIV to health departments through the 1990s. In response to these concerns, CDC and health departments implemented unprecedented, strict policies and procedures to ensure security and confidentiality of the data. The use of these data was severely restricted. Because of community input, coupled with the fact that there weren't good prevention and treatment options at that time, most programs did not use the data to implement individual-level prevention efforts. So let's talk a little bit about how we use public health data. As a result of strict data use policies, our initial uses of public health HIV data were primarily focused on describing populations. I'm going to switch over to an interactive tool here. Although the data are not real, imagine for a moment that each dot on this slide represents a person with newly diagnosed HIV infection. Public health data help us to better understand who's being affected by HIV. For instance, how old they were when they found out they had HIV. Here we can see that a lot of people are in their 20s when they find out that they have HIV. We can also look at their race, ethnicity, and this is how we can learn that some groups are disproportionately affected by HIV. We can also look at other information like what part of the country they live in, or how they likely acquired HIV. This information can help us to better understand what types of prevention are needed, by whom, and where. It's also important in identifying disparities, whether those disparities are occurring among racial ethnic groups, certain parts of the country, or LGBT populations. And this is important in allowing us to determine when certain groups need additional support to overcome barriers they might be facing. We also know that public health data need to evolve over time. For a long time, our reports of public health data have focused on sex at birth. However, we've been working to collect improved data on gender identity, which allows us to better understand the needs of transgender populations. Additionally, as our prevention options have broadened, we've begun using public health data in new ways. Health departments can now use public health data to identify people who appear not to be receiving HIV care. They may need additional support to access HIV care and succeed at maintaining viral suppression. This is sometimes called data to care. We can also use public health data to determine when there might be an increase in HIV transmission. For example, we might find that a particular county, which typically has only a few new HIV diagnoses in a typical year, all of a sudden has a lot more than expected. This might signal that there's an outbreak, perhaps like the outbreak of HIV that occurred among people who inject drugs in Scott County, Indiana in 2015. This would be a signal that public health should respond to try to stop transmission. Now we have a new tool for identifying situations where there's increased transmission. We can use laboratory information to identify when there are groups of infections that are very similar, much like public health does when looking at outbreaks of tuberculosis or foodborne illness. For example, here you can see several growing clusters. For HIV, when we find a group of similar infections, it suggests that they are all part of a common network. These similarities also tell us that HIV likely spread quickly throughout this network. So let's zoom in on one of these networks. Focusing extra attention on these networks can help us to see what resources are needed and target our outreach efforts. For instance, by contacting partners of people with HIV, partners of people in the network, we can work to identify other people who might not have known they had HIV, or help people who are at high risk of acquiring HIV to avoid getting it. We can also work to understand what barriers may exist and identify ways to help reduce these barriers so that people can get the prevention and care that they need. So I just showed you that we can use laboratory data to identify networks in which HIV is spreading rapidly. So what are these lab data? Well, as part of HIV care, healthcare providers order testing to learn which treatments will work best for a person's HIV strain. This is called drug resistance testing, and it involves determining the genetic sequence of the virus, not the person. We sometimes call this molecular data. This information helps the provider to make treatment choices, and you might have heard people refer to the collection of this information by public health as molecular surveillance. Drug resistance testing is important for providers to know which drugs to prescribe, and it's also important to monitor in the population. If many people develop resistance to commonly used drugs, it can make HIV more difficult to treat. These molecular data can be used to help inform public health activities. HIV mutates over time, and it mutates a little bit differently in each person. These mutations add up and over time lead to changes in the genetic sequence of the virus. Public health agencies can analyze the sequences or molecular data to find groups of infections that are very similar. This indicates that HIV is spreading quickly because it hasn't had time to change much between transmissions. In fact, we've found that in these networks, HIV is spreading 10 times faster compared to the average. When we find these networks, we can then reach out to them to provide the services that they need, understand barriers to care and prevention, and develop approaches to overcome them. This can be done through a variety of methods, such as social networks testing strategies, which involve people recruiting other people that they know for services like testing and PrEP. We've already seen some examples of how identifying networks of rapid transmission using molecular data or other approaches can strengthen prevention efforts. For example, Texas identified a large group of Latino, gay, and bisexual men in San Antonio with very similar HIV strains. 24 men were initially identified as having similar strains of HIV. After CDC and the health department followed up, another 87 people were identified as being sexual or needle-sharing partners within this network. So how did this help the health department? Well, additional information gathered by the health department revealed that HIV testing wasn't always conducted according to guidelines. And as a result, providers had missed some opportunities to diagnose people at the stage of acute infection, which resulted in delayed treatment. In response, the health department sent an alert to providers clarifying the guidelines for and importance of HIV diagnostic testing and diagnosing acute infection. The investigation also highlighted a lack of access to pre-exposure prophylaxis for many who could benefit from it. So the health department's alert that was sent out also worked to increase awareness of PrEP. In addition, the health department redirected funds to increase access to PrEP in specific areas of the city. Responding to this situation brought together a new coalition made up of community members, providers, and public health staff in San Antonio. And as a result, the coalition provided the support that enabled San Antonio to sign on as a fast-track city, with commitment from the mayor and city council to working together to reduce stigma, improve care, and eliminate new cases of HIV. So here you see, these are some things that health departments are already working on, making sure that people are educated about HIV and that prevention services are reaching the right populations. This is an example of how cluster detection can lead to an opportunity to identify gaps in those services and how the health department can redirect efforts to make sure that the services are reaching the populations that need them most. As I mentioned, sometimes we identify a possible increase in transmission by seeing an increase of cases in HIV. Here's one example of that scenario. The West Virginia Health Department identified an increase in HIV diagnoses among gay and bisexual men in a part of the state that typically has few HIV diagnoses. Because injection drug use is common in that area, the health department was also concerned that HIV might spread into communities of people who inject drugs. So with help from CDC, they conducted in-depth interviews. As a result of what they learned, they increased access to HIV testing by relocating some testing sites and increased awareness of the need for testing through radio and social media ads. The health department also established syringe service programs in counties that did not previously have them. Sometimes it's actually a healthcare provider that identifies a possible increase in transmission. In this example, which occurred in a medium-sized city in a northeastern state, a healthcare provider called the health department to report concern about increased diagnoses among heterosexuals. Laboratory data showed rapid transmission among this group. As a result of the findings, the health department worked to establish a PrEP provider in the region, held a regional provider meeting to educate providers on the issue, and expanded HIV testing in jails and reproductive health clinics. In this fourth example, which occurred in a Midwestern state, laboratory data identified a growing network of rapid transmission. The thing that was surprising was that even though everyone in the network was virally suppressed, the network continued to grow. This suggested that there might be additional people who hadn't yet found out they had HIV. So the health department and HIV providers worked with their patients to encourage them to help increase testing, linkage to care, and prevention among people in their social networks. In our last example, one city in a southern state is using laboratory data to identify growing networks. As part of this work, they're working with community-based organizations to use peer recruitment strategies to reach affected communities with HIV testing and PrEP education and referral. So now we'll talk a little bit about community concerns that have been raised and in community engagement. I want to start by saying that CDC is committed to maintaining high ethical standards and minimizing any risk that public health data could be misused or misinterpreted. We know that public trust is the foundation of our work. Public health agencies collect data and use it to improve health. This offers a benefit to the public. This is how we know what we know about HIV in the United States. It helps us to build programs to serve groups of people living with or at risk of HIV, identify health inequity and work to end it, and reach out to people who need additional support or services. However, in this work, we must protect the data and ensure it is used for the health of individuals and the community. State and local health departments have a duty to improve the public's health, and as part of that responsibility, they collect personal information when people are diagnosed with reportable illnesses, including HIV. These agencies have many protections in place to safeguard people's information. Some of these policies and procedures to protect the data are required by CDC, and health departments have additional protections in place specific to their area. Whether it's CDC or your local health department, we keep all public health information on secure data systems and only allow people to access information if they need to know it to do their jobs. We also require people with access to HIV data to complete a data security training annually and to sign a binding confidentiality agreement. Personally identifiable information such as name, address, phone number, or social security number is not sent to CDC. It is our goal to use these data to help improve people's health. We've been talking with a variety of people about this work, and there have been a number of questions and concerns raised, including the extent to which public health activities will be conducted in ways that are culturally sensitive and non-coercive, which is certainly our goal. People have also raised questions about the level of protections for public health data. People need to feel their data is protected from improper use. Data held by CDC is maintained securely according to strict guidelines and regulations, and we require that state health departments maintain their data securely as well. We've heard your concerns that molecular analysis could tell who infected whom and be used in criminal proceedings. We are emphasizing that health departments need to assess their existing data protections, ensure they are adequate to protect against non-public health purposes, and assess whether their jurisdiction has criminal exposure laws. Many of these laws were passed before we had the tools and evidence on ways to decrease risk of transmission, and they are now outdated. Currently, our molecular technology and analysis cannot tell us who infected whom. We can only tell that the viruses are closely related. Right now, we don't want or need molecular analysis to provide a direction. We need it to detect growing networks of rapid transmission, and we are interested in protecting the data against use for criminal cases. Finally, people have wondered how CDC and health departments will engage the community, and I'll talk a little bit more about that right now. Community engagement is critical. We always recommend that health departments engage their communities around the work they are doing, because we know that we're all working toward the same goals and that community members have a lot to offer. Given that cluster detection and response is new and there's still a lot to be worked out, engaging the community is particularly important. Community engagement aims to inform the community of the program, engage stakeholders, and hear their priorities and ideas. This offers the opportunity of building support and also of identifying ways that we can partner with the community to achieve our common goals. It also honors past processes and agreements with the community. All health departments that receive CDC funds are expected to engage their communities in the development of prevention plans and priorities. Health departments may use a variety of methods to do so, including prevention and care planning groups, meetings with local healthcare providers, community-based organizations, and other stakeholders, and community advisory boards. We're also expanding community engagement at the federal level. In September, we held an informational session at USCA to discuss this work and upcoming community engagement plans with community members and advocates. We're also having a series of webinars starting today, which will allow broader participation than in-person meetings. This is actually our first webinar, and we also have one planned today for CDC-funded community-based organizations. We're also planning additional webinars to reach other key groups, such as networks of people with HIV and LGBT groups. Additionally, in early 2019, we will convene representatives from CDC, health departments, and community with expertise in public health ethics and law to discuss best practices in data protections and data sharing. We'll also conduct additional community engagement around the National HIV Prevention Conference. We're committed to addressing specific concerns that emerge, especially concerns around policy and communication issues related to cluster work. We're interested in hearing your questions, thoughts, and concerns. However, before we move into the discussion portion of the presentation, I wanted to close by saying that we can end HIV. We're at an exciting time in HIV treatment and prevention. We can detect infection and networks of infection earlier than ever, saving lives and preventing transmission. CDC and health departments are committed to using both traditional public health tools and the new tools in our toolbox to end HIV. We are also committed to responsible use of the data, to hearing your concerns, and to working with communities to address them, and to using the data we have to more effectively reach and serve more people with or at risk for HIV. We're now going to move into the discussion phase of our webinar. We want to thank you for participating. We hope you found this information useful. We're actually going to start with a few questions in an online interactive format that will allow us to hear more broadly from many of you, and then we'll move into some open Q&A time. So for this portion of the webinar, in order for you to be able to log your responses, you can use a phone or any digital device that you have and go to menti.com. That's MENTI.com. When you get there, it's going to prompt you for a code, and you'll see the code here on the screen. It's 390677. So I'm going to pause for a moment and allow you guys to go ahead and get into that. As I said, you can use any mobile phone if you have it with you, or you can switch to that on your computer. And again, it's menti.com, MENTI.com. And when you get there, the code is 390677. And I just want to say that as you guys are getting there and logging in, we've been using this tool recently because we realized that when we have large conference calls, whether it's with community members or health departments, it's really hard for everyone to have an opportunity to ask their questions, and some people are more or less comfortable asking questions on a big call like this. And so this is a tool that we can use to make sure that we hear from all of you. And like I said, we are going to have some open discussion time when people can ask questions and we'll answer them. But because we know we might not get to hear from all of you during that time, this will give us an opportunity to have something that we can go back to afterwards. What we'll do is we won't necessarily be able to look at or address all of the questions that you raise in this format on this call, but please be assured that we will use that afterwards to make sure that when we develop future communications and future materials, and as we think about how best to roll out these programs, that we're incorporating your concerns, your thoughts, your input. So hopefully most of you have gotten in. What we're going to do is go ahead and start with this question, which should have popped up on your device if you're logged in. Before today, how familiar were you with HIV cluster detection and response? So this is great. It looks like 15 people have answered. Keep answering. Give you guys a couple minutes to, not a couple minutes, maybe another 30 seconds to answer this question. So it looks like a lot of you are saying this content was familiar. Many of you are saying that you had heard of this, but this provided helpful information. And some of you are saying this is the first time you'd heard of this. So that's a good cross-section. Give you another 10 seconds or so to keep answering this question, and then we'll flip over to the next one. And just so you know, if you're in the middle of answering the question, when I switch, it'll still allow you to stay on that screen and record your answer and then move on to the slide that I'm on. Okay, so now we're going to move on to the next one. How had you heard about cluster detection and response before today? So the answers are I hadn't heard of it through CDC, through the health department, through news, media, or social media, through advocacy or community organizations, or other, and you can choose more than one. Right. Good, the bubbles resized. I was thinking the whole screen was going to be covered in bubbles. All right. Great. It looks like a lot of you have heard about it through the health department, through advocacy or community organizations, through CDC, and then a smattering of others. So great. That's good to know. Thank you. Okay. As I said, you can keep answering that if you're still logging your answer, and then move on to the next question when you get a chance. Okay, so this is actually an open text response. So in a few words, share your initial reaction to the content included in this presentation. So, just a few words here. Your sort of first impression would be helpful. Great. It looks like people are able to get their things entered. Great. Thank you, guys. I see that a lot of you have had an opportunity to enter your comments. It sounds like it was helpful for a lot of you. Some of you have some thoughts about what could be more useful. We really appreciate this. So I know some of you are probably still entering your thoughts, so keep on typing. I'm going to go ahead to the next question, and then we'll continue to get your feedback. Okay, so the next question is, what do you think are some benefits to cluster detection and response? Just to give you a heads up, the next question is about risks. So here you can add anything that you think is a potential benefit. And just as a reminder, we will be having some open Q&A. We just have a couple more questions, but it is really, really helpful for us to get this information from all of you. And again, I guarantee that we will be looking through every response after the call, and we'll be thinking about that as we think about what we can be doing better in terms of how we implement this work and how we communicate about this work. Excellent. It's great to see your responses coming in. Thank you so much. Great. We'll give you guys another 30 seconds or so, and then we'll move on to the next question. Great. So if you're in the middle of typing, please feel free to continue typing and hit submit. In the meantime, I'm just going to go ahead on to the next question. Thank you guys so much. All right, the next question is, what do you think are some risks or drawbacks of cluster detection and response? Thank you. I see some of you are raising issues around stigma, criminalization, ethical issues, confidentiality and privacy of data. These are issues that are really important to us, and we're really spending a lot of time thinking about them. It's good to hear what some of the concerns are that you guys have. We want to make sure that we're doing everything we can to try to address community concerns and make sure that we're implementing this in the most appropriate way possible. Another 15, 20 seconds, and then we'll move on to the next question. Thank you. We really appreciate you sharing your thoughts with us. Okay, I'm going to go ahead on to the next question. how might we best address these risks that you've just raised? We really are interested in your ideas about what we can be doing to help address them. And this is our last question in this format for the moment, and then after this question, we'll be going to the more open Q&A. So please share your thoughts. All right, great. Thank you guys so much. Again, you can keep typing in if you're in the middle of your response. While you're entering that, we're going to go ahead and minimize this.
Green.
No.
Okay.
Are you clicking? Okay, go.
There. Great. Okay, so we're going to move into the Q&A. I'm actually going to turn it over to the operator so that she can give you instructions on how to queue up with questions. We also are seeing that some of you have typed questions into the chat box, and so we'll take a look at those and see whether we're able to address some of those as well. But right now I'm going to hand it over to the operator.
Well, thank you so much. If you'd like to ask a question over the phone at this time, please signal us by pressing *1 on your telephone keypad. If you're using a speakerphone, please make sure your mute function is turned off to allow your signal to reach our equipment. Once again, that's *1 to ask a question. We'll pause for just a moment to allow everyone an opportunity to signal for questions. It appears we have no questions in our phone queue at this time, but just a reminder, it is *1 if you do have a question or comment.
Okay, well, feel free to queue up. In the meantime, there have been some questions entered into the chat box, and we'll go ahead and address those. Sorry, I'm having a hard time. Let's see. So I saw one question that asked about why we didn't identify the health departments that we mentioned. So some health departments have publicly reported on clusters that they've investigated, and so in those cases we did name the location of the cluster. However, we always want to work with our health departments to make sure that we aren't sharing information that they haven't yet informed their community about. And so we erred on the side of not naming the city or state if we weren't sure whether they were comfortable with us doing that. Thank you. I think some of the things that are in here look like they are sort of responses to some of the questions, so we'll pull that in with the other data from Menti. Someone said the CDC did not educate the public on this before it was rolled out. We are always trying to do what we can to do better, and we recognize that community engagement is important. It really needs to be happening at all stages. What I can say is that right now we are working with our health departments to convey that community engagement around this work is really important, that it's important that health departments work with all of their partners both inside the health department but also in communities to make sure that everyone is aware of what's happening and can contribute to making sure that this work happens in the most effective and appropriate way possible.
How do we address?
Oh. Where?
See what in the yellow.
Yeah. What do I do?
Just to let you know, it appears we have no questions in our queue at this time.
Hi, I see that someone's asking how do we ask questions via the computer audio. There's a way that you need to queue up. Maybe I'll ask the operator to repeat those instructions.
Oh, certainly. Once again, just a reminder, it is *1 on your phone. If you have a question via the phone, that's *1. If you're using a speakerphone, please make sure your mute function is turned off to allow your signal to reach us.
And I think it may be that if you're only listening on the computer, you need to type your question into the box. Someone asked if this is being recorded. Yes, we are recording this and do plan to make it available for those folks who aren't able to attend today. Just this question, how does CDC plan to address community concerns? You know, we are working both internally in CDC and with our health departments to address community concerns. I mentioned some of the community concerns that have been raised around data protections, community engagement, criminalization, and we're actually working to share additional implementation guidance with health departments that indicates the importance and the fact that they really are required to conduct activities to make sure that this rolls out in a way that's appropriate. And so that includes things like engaging the community around this work. As I mentioned, they should all be engaging the community as part of their standard HIV prevention planning, but it's really important to make sure they're talking with communities about this work in particular to get their feedback and their concerns and see what they can do to address it. Addressing the level of protection for their data and the implications of whether there are criminal exposure laws in their state, and some other activities involving collaboration. So we are hearing the concerns of the community, and we're taking steps to make sure that the level of focus that goes into those activities is heightened.
It appears we have a couple questions in our queue at this time. We'll take one from Joyce Roundtree McCoy with Delta Health Center.
Oh, hi. I tried to type. I asked, like, is it being recorded? And I heard you say that it is being recorded for those who weren't able to attend. But do we get a copy of it too, the ones who are attending as well?
I think we're planning to post it on our website, okay. So we can try to make sure that the information goes out to the same list that received the invitation to this call.
Okay, great. Thank you.
We'll move on to Nina Khanna with Positive Women's Network.
Great. Thank you so much. I have a couple of questions. One is, even though the science has advanced, has not quite advanced such that directionality of transmission can be shown from the technology that CDC is referring to. Our experience in communities is that judges and juries and the general public do not understand that. And so there is still potential for misuse of this data in criminal proceedings and prosecutions. And so I'm wondering what steps CDC is taking to address that. Secondly, it's our understanding that the directionality science is only, it's not that far away. And so that data will actually be available. And I know you mentioned earlier that CDC is recommending jurisdictions check on their state laws about exposure. Unfortunately, there's not a lot of checking that needs to be done. We already know that over 30 states and jurisdictions in the U.S. already have some version of laws targeting people living with HIV on their books. And these are going to have to be undone state by state. And in fact, even in states that don't have these laws on the books, people are being prosecuted and criminalized as well under other types of general public health statutes and laws about transmission of communicable diseases. And then my third question is, what steps is CDC taking to protect this data from other federal agencies within the government?
Thank you so much for those questions. You know, we share your concerns. We agree that there is the potential that, you know, data could be misused if they're not adequately protected. And so we feel like it is really important that health departments work to shore up protections for HIV surveillance data and try to develop policies, procedures, or laws that help to protect public health data from use in criminal proceedings. So we're working on legal analyses and working with state and local health departments. We also have that meeting that I mentioned planned in early 2019, and data protections is going to be a big focus of that. We're working on ways that we can provide additional tools to health departments to help them to protect data, as they are all interested in doing as well. We also are encouraging states to look at their criminalization laws. You know, I hear you. We know that criminalization laws exist, and we know which states have them. We also know that other states can sometimes use other statutes. And so the best that we can really do is encourage states to look at them, assess whether they are in line with the current state of HIV prevention, and think about whether it's appropriate for them to modernize. The third question that you asked was about other federal agencies. That's something that we haven't thought about quite as much. We haven't had any situations that I'm aware of where other federal agencies have asked for those data. I think it's something that we should absolutely add to the list of things that we're considering as we look at these data protection and legal issues.
Great. Just one final follow-up question. Do you think that because of the risks of criminalization and prosecution, and you know, it's great to hear that CDC is examining this and will be convening a consultation in 2019, but there are people facing criminal proceedings right now. And you know, there are criminalization cases that are happening all the time, unfortunately, in the United States, and particularly vulnerable communities are at sort of increased risk for surveillance and policing, including trans communities, including immigrants, including people of color, the very communities that are also disproportionately impacted by HIV. And so do you think that the CDC should institute a moratorium on collecting this data until these protections can be figured out at the state level uniformly?
Thank you. Yeah, you know, we hear you. Those situations are very concerning. But unfortunately, those situations happen even without these data. We're not aware that molecular surveillance data have been requested from any health department for criminalization cases. We certainly know that criminalization cases are underway at all times, but we're in an active process of balancing the benefits and the risks of collecting this information. We see a lot of benefits. We also see risks. You know, right now we're trying to work to do what we can to mitigate the risks, but we also feel like it is really important for health departments to respond when they see that there are communities in need, and have information and tools that they can use to do so. Operator, are there any other questions?
And we do have an additional question in our queue. It's from Arthur Powers with Thrive.
Thank you very much. I just want to point out that Colorado has serious protections with regard to information held and maintained by the Departments of Health, both the state and local, and help particularly with regard to preventing the pursuing of criminal actions on the part of any authority in the state, excepting by the Departments of Health specifically and only with regard to persons who are, as the law provides here, perceived in emergency circumstances as public disease control risks. And the specific wording that we have reads as follows: such information shall not be released, shared with any agency or institution, or made public upon subpoena, search warrant, discovery proceedings, or otherwise. And then there are exceptions under any of the following circumstances, but these circumstances identify the release of information that's anonymized for statistical purposes and for, as I indicated earlier, releases may be made to enforce the disease control provisions of Colorado law in connection with disease control within the Department of Health context and, if you will, institutional calculus. There are a few other exceptions, but we have that basic fundamental language that has been very successful over 30 or more years now, inhibiting the use of information collected and held by the Departments of Health, state and local, for criminal pursuit purposes, again, excepting in contexts where individuals are perceived as, on an emergency basis, public health, direct public health risks, and have been extremely recalcitrant in their responsiveness to steps taken on an gradually escalated basis to cause the person who's perceived as a public health risk to cease and desist in the behavior that is creating, apparently, for the perception that they are a public health risk. If they are thought to be so, in Colorado, there's additional protective language that provides any such individual who is thought to be so with the right to legal representation, the right to district court review, the right to, and various other rights that are extremely civil liberties protective, where a person may challenge the perception of that person being perceived as a public health risk as such. So having an architecture of laws in a state and can be exceptionally important, and in Colorado has proved to be so in terms of allaying these concerns to a high degree, if not a total degree, over the last since 1987, when these laws were passed. In addition, any improper releases of information, according to Colorado law, may be pursued criminally by law enforcement against the Department of Health itself, and any individual in the Department of Health, local or state, can have, if they are found guilty of improperly releasing information outside of the confines of the law, may be subject to 6 months to 2 years in county jail, or subject to a I believe it's a $5,000 fine. So we've got some excellent law, relatively speaking, compared to other states, that might serve as a useful paradigm for other states to work with and possibly indeed to improve upon, to prevent and to allay criminalization efforts and criminalization concerns, respectively. Thank you.
Thank you so much. Yeah, I think those are examples of best practices and the stringent policies that are in place to protect data in many states. And our interest is trying to bring all states up to a high standard of protecting data. We only have a couple of minutes left. I wanted to mention a couple of things. One question was whether the slides would be available. We can make the slides available when we post the recording. We have, I think, email addresses for everyone who registered, and so we can make sure that that recording information and the slides, that the link to that gets sent out to the email list that received this original invitation, as well as anyone else who registered. There are some questions about what are we doing around criminalization. You know, CDC has there are limitations on what CDC can do in terms of requiring or advocating for law changes at state levels. But what we always want to do is, it's our interest that laws are modernized to reflect the current science. We can educate, we can encourage states to look at what they can do to modernize their laws, and so that's the role that we're taking. So we have, let me just take a moment and see if there are any others that I can answer quickly. So there was a question about how this differs from data to care. Data to care is about finding individual people who appear to be out of care and working with them to help them overcome barriers and get them into care. We see cluster detection and response as it can operate at that level. It can certainly link in with data to care, but it really is a powerful way to identify those bigger picture issues, bigger picture barriers, and help redirect prevention efforts at a larger scale than just the individual level. So unfortunately, we're seeing a lot of great questions. We are close to the end of our time. What I wanted to do is just go back to the Menti interface. So if you still have it up on your screen, we had one additional question. Sorry, I don't get to. Well, I can't seem to advance it. The last question was actually just if you had any questions that weren't answered to type them in. So it seems like a lot of you have done that in the interactive interface on ReadyTalk. So if you did have any other questions that weren't answered, if you can type them in on ReadyTalk. I sincerely apologize that we didn't have time to get to all of the questions that were raised, but we will again include this information as we think about how we can improve these types of presentations in the future. We're also developing information that's available on cluster detection and response, and we can consider adding some of these to our frequently asked questions and to other materials that we develop. Okay. Well, then I think that we are at time, and so I just want to thank you all for participating. We know this is a process, and we're really trying to work through this and hear your concerns and do what we can to address them. So please do believe that we're going to be taking this information back and thinking about how we adjust our plans and our guidance and everything else moving forward. So thank you very much.